Hello and welcome to the Aesthetic Insider Show. I am so excited about today's guest, Dr. Toby Mayer. Dr. Toby Mayer is a Beverly Hills facial plastic surgeon and pioneer in facial feminization for the transgender patient. Dr. Mayer, welcome to the Aesthetic Insider Show. It's always such a pleasure to be speaking with you.
Oh, thank you, Angela. My pleasure to speak with you.
Absolutely, absolutely. We've got so much to talk about. There's so many changes and transitions and just wonderful things that have happened in terms of facial feminization, where it started and where we are with it today. But let's first start, Dr. Mayer, with you just telling our audience who you are and who your beautiful assistant is.
That is Sammy. This is my consultant.
That's amazing. I love it. Sammy, it's lovely. But yeah, so please, tell our audience who you are and how you began with your work in facial feminization.
Well, almost 50 years ago, I had a patient come to me. I was a facial plastic surgeon, and I had a patient come to me and a transgender patient and wanted to have facial feminization. And I thought, my God, I'm doing the third transgender patient in the world, because everybody at that time was in the closet except Christine Jorgensen and Renee Richards. And both of them were the only people anyone knew about who were transgender. So I did that patient. And then she said, oh, I was wondering if you could do something about raising the pitch of my voice. And I said, well, let me run it by the famous laryngologist. And he said, after I told him, he said, oh, that won't work. And the patient said back to me, I don't care what he said. Are you going to do any harm? And I said, no. And she said, well, go ahead. And it worked beyond my wildest dreams. So little by little, I started doing not only facial feminization, because at that time I also did the flap procedure, and then shortly thereafter tissue expansion. And these were remedies other than hair transplants, which I felt were the least wonderful treatment of hair loss in male to female transgender patients. And those are the only ones I did, only male to female transgender patients. So I got referred a large number of patients, and little by little, I developed other procedures to feminize. At the time, there was only, unbeknownst to me, one other surgeon, Dr. Osterhut, who was a general plastic surgeon, and he was the only one, and we did things totally differently. So little by little, I saw some of his patients, and eventually he saw my patients. And that's how it all began.
So just to clarify, when you talk about the flap procedure, that is the hair flap, that procedure that you...
Correct. The hair flap is for patients who... Yes, the flap procedure is what we call a temporoparietal occipital flap, and it was originally developed by Jury in Argentina, but it didn't look good because it had a lot of things that were bad, but it also had a tremendous number of advantages if it could be improved. Yeah. So I believe it was like 12 different things I did to that procedure. And then we could take a piece from the side, flip it to the front, and remove 2 inches of bald scalp and throw it in the trash, or use it for parts. And that's what I did. So that became very, very popular at the time. But surgeons didn't adopt it because they could make more money doing grafts, and they didn't have the technical ability at that time to do flap procedures because it wasn't part of training for general plastic surgeons or for facial plastic surgeons.
Yeah. But so now back to the facial feminization, of course, with the male to female transition, some of those transgender patients may also have hair loss. And so what you're saying is you were able to use a technique you had developed really for the balding man to create a hairline and new hair, basically more feminine hair for that transgender patient.
And it was hair without a texture change. Hair transplants are wiry, kinky, and you can't get really the density that you can get with a flap procedure. Yeah. So that's this hair on the side of the head. And so the hairs are, if they're this close together, number one, the technique that I invented would allow the hair to grow through the scar. So you didn't have a scar in the front, which was the major disadvantage for a lot of people in doing this procedure. But since that time, as a sidebar, I've taught that for almost 50 years since I started doing it. And that is the simplest thing that I teach. And Osterhut, just all of his patients had a curved white line. And in order to make this look good, you had to not have a scar. So I used the technique, whether it was hairline lowering, they had enough hair, but it was just too high, and the scalp was mobile. I could just lower the hairline. And at the same time, I developed a technique different than Osterhut. He used to take this supraorbital bone, take it off, go put it back on. I never met a patient who needed that. I said, no, we can just take the bone down. And that's what I've done. And so I would lower the hairline. Most of them needed a brow lift, if not all of them. And at the same time, remove the supraorbital bone. So those three things combine what we call the upper third. Raise the brows, lower the hairline, remove this. And that was if a patient had mobility. But what if the patient didn't have mobility? This hair was good, but it was just too high, and you push down and nothing happened. Then I put a tissue expander underneath here and was able to lower it wherever I wanted. Or if their hair was so far back or they had full male pattern baldness, then I would do the flap procedure. Because they were male to female transgender patients, they were on estrogen. So we didn't have to worry about future hair loss. So this could be, for the majority of patients, this was extremely advantageous to them, as long as you could do it without serious complication and without leaving a bad scar in the front. And so that's what I did.
And I think, for kind of our viewers is, the difference in the transgender male to female patient is the patient wants female hair. So they want to wear their hair off their face. They want to grow their hair long. And so, like you said, if the hair transplants grow out different, they're kinky, it's just different quality of hair that is growing versus their natural hair, which you have been able to, through the tissue expansion, expand that hair scalp into them having just a more suitable female appearance in their hair. Would you agree with that?
Sure. And I can show you some photos that demonstrate that. So if we look at the hairline, when I'm finished, looks like that.
Okay.
So the hair is, I've raised the brows, lowered the hairline, removed the supraorbital bone, and that's the resultant.
Very natural.
After I finished with all that, it's very natural without a white line. And then here's another one. And it depends if the hair, that one, for example, is not quite as dense. Her hair was not as dense as the previous one, not like this, where the hairs are right next to one another. You cannot achieve that look without kinkiness with hair transplants. You will not get that result. So if patient doesn't want it, that's up to them. But I point out to them the difference between the two, and I make sure that they know that they won't get end up with a scar that looks like that.
Yeah.
So what does it mean? It means that patients can go from that to that.
Yeah.
So I'm all about proportion, not just making things smaller. So, for example, I never do jaw surgery where I remove this, because this proportion in Brad Pitt and Angelina Jolie is the same. It's all about the proportion of that. So if we look at this and you said, oh, tell me, is this picture of Angelina Jolie, what is the difference between that and Brad Pitt? It's skull size. The two have the same proportion. So removing this, number one, it does nothing from the front view because you can't see my fingertips because they're on the bone, and this is in front. So removing it changes nothing from the front. But when the patient turns like this, now you see an abnormality where this has been removed. And when that is removed, it makes this look larger and not proportional.
Interesting.
So the difference between Angelina Jolie and Brad Pitt is not proportion, it's skull size. And I haven't been able to shrink the skull because there's a brain in there.
Yeah. Well, that is interesting, and especially because I do think, like you talk about the proportions, and I would imagine with the facial feminization patient, you have an array of male to female transitioners, if you will, who have many different sizes and scopes of skull size. So how do you help define like a patient who is the best candidate for facial feminization?
If we look at this patient, once again, and you see that her proportion has remained essentially the same, what I've done is remove the hallmarks of secondary male sex characteristics. That's the supraorbital bone, the hairline, the position of the brows, cheeks, nose, chin reduction, etc. So if we look at this patient, no jaw surgery. She's had the other elements that it says there, where she's had her nose, her upper third, her chin, cheek implants, etc. But no jaw surgery.
Okay.
As a sidebar, I'll see patients like this who have male pattern baldness, but with a flap. They can go from that to that with a tissue expander, and they'll look like that a week later after the flap has been moved.
Now, they'll just a hair flap patient, correct? This is not a...
Correct, yes. It's just a hair flap patient, but it would be the same for a transgender patient, no different. Because I will see transgender patients look just like that. Yes. And you see, you can't just lower the hairline because you'd end up having to use thousands of grafts for the recessions. Whereas one flap does everything. And in transgender patients, I place grafts only after I've narrowed their recession, this V. I take it and I narrow it this way, and then I use grafts just for the remaining little bit. On a male, you don't do that. For example, that. So that's 15 years later after one flap. Patients never needed a second flap. Okay? So the difference is we want to have patients who, once again, are in where you have that before You can say, oh, yeah, she needs jaw surgery. No, she doesn't need jaw surgery. She needs chin reduction because that is a very large chin. And then she had hairline advancement, brow lift, orbital bone contouring, her rhinoplasty, all the things that it says underneath there. So patients like this because it gave them a very natural result.
Yeah. So let's talk a little bit now. I mean, you've been doing this for 50 years.
Yes.
Thereabouts. And you have obviously, fast forward now to today, there's obviously been many advancements, surgical advancements and improvements. But you have gone from, having one patient and one physician who also did facial feminization, albeit differently than you, to today where your whole practice is pretty much facial feminization for the transgender patient, and the hair flap and some of those other techniques that you're known for. What has brought about this huge change in acceptance?
That is the key. The acceptance. So as I said before, I thought I was doing the third transgender patient, but there are like 1.3% of the population identify as transgender. So that number was like, oh my God. Well, I found that out right away because I was seeing a large number of transgender patients, but they were all in the closet. Because if they came out, they would lose their jobs, society would look at them funny. So what's the change? The change came about and was popularized about the time of Caitlyn Jenner, where her work was not necessarily popular in the transgender community, but it was a discussion of this in the public. So up until, let's say, 10 to 15 years ago, plastic surgeons, number one, did not want transgender patients in their practice. So Osterhat and myself essentially did everybody in the United States and beyond for all that time, for 35 years before you ever heard anyone else mention transgender surgery. And then other surgeons. Now, if we fast forward in the last 15 years, there's a smattering of surgeons who call themselves transgender surgeons. There's no certification. If you go to a residency program, you say, oh, can I get a degree in facial feminization for transgender patients, male to female? And the answer is no. Anybody can call themselves a transgender surgeon. So if we look at what that looks like when this happens, we have this patient who's been to another transgender surgeon, and this is what she got for a considerable amount of money. And she's got a white scar that goes all the way across her hairline. She's pushed her hair forward to try to cover it. Her brows still are too low. She actually had what Osterhat called the type 3, and the bone is still there along with the titanium because you see that white light reflex. Her nose was scooped out. God does not make scoops. That's just not the best rhinoplasty, to try to be kind. And then the chin, she paid for a chin reduction, and that is not a reduced chin. So you look at that and you say, oh, the doctor who did this calls himself a transgender surgeon. And this is not the kind of result that she wanted. So I revised everything. Now she's had a proper brow lift. The scar has been totally removed. She now wears her hair exposing her hairline because there's no white line. Her nose has been reconstructed to a pretty female, feminine nose. Her chin has been properly reduced. So that's the kind of surgery that these techniques have been there. I've taught most of these, but not all of them, because if you can't do this procedure without leaving a scar, making a hairline lowering without a white line, that's the easiest thing that I teach. So I would, certain things I do not teach, because patient like the voice procedure, that would be, patients could easily be very injured. And I've never had any complication from that other than a stitch, a permanent stitch that I had to remove afterward. What came up to the surface, you scrap it, cut it, boom. That's it. No other problems. So there is no standard for this.
No. However, I think that the acceptance on the part of the public has made it safer for the transgender community to
totally
move into the life they've always wanted. Correct?
Yes. Yeah, absolutely. That is the biggest change, because you look in national surveys, the majority of the population now is okay with transgender patients. There's, you have Pride Month. My God, the idea of Pride 50 years ago, they would have taken me to the loony bin. How about 20 years, 30 years ago? Same thing. It never, patients found out that their neighbors, their relatives, etc., everybody knew somebody that was trans, and it became not something abnormal. It was like patients being gay. It's just an is.
People.
I will get asked socially. They say, "Oh, I hear you do transgender surgery. What's it like with those people?" And I go, "Well, those people, wow, they are so, you know what they want? They want to live like the person inside them. It chooses them. No one ever got up in the morning and said, I want to be transgender. It doesn't happen that way. It chooses them. And then they want to be like the rest of us. They just want to be happy, live their lives without being bothered by anybody. They want to love another human being and be left alone." And that's the biggest change in this last 15 years, because when people then started coming out, they said, "Oh, that's so-and-so's cousin. Oh, I didn't know they were transgender," depending on the quality of the work.
And now, like previously in our conversation, you mentioned celebrities, and we're in LA, we're in Beverly Hills, Hollywood, and the to coin a phrase, I think is probably one of your phrases, is face equals fortune. And I would think in the transgender community, yes, face equals fortune, but the face in the male to female is so important for that outward appearance that truly changes their life. It changes their opportunities. It changes their confidence level. It just makes them feel, like you said, like they can move through society as the person they are inside.
Yes. So when I'm asked about this, they say, "What do you do?" I said, "I change lives one face at a time," because these patients that I see, they come in looking male. 6 days later, they go home and they're swollen, but you can't tell the swelling. You can only tell bruising. And so they look totally different. Let me show you an example of what that looks like. Hold on a minute. Patient comes in looking like that, goes home looking like that. But the question is, I'm asked with each patient, what am I going to look like 6 days later? Well, patient comes in looking like this. I take the photos on Monday. They go to surgery the next day, and then 6 days later, they come in to have their stitches out, and they look like that.
Okay.
That patient has had everything done other than her voice. If you lifted up her bangs, you'd see I just took out her stitches. But she could put a little cover up on and go to a party that no one would know she had that surgery 6 days ago. That's her upper third, brow lift, orbital bone contouring, hairline lowering, nose, cheek implants, chin reduction, Adam's apple shave, etc. She's swollen, but nobody will know that. Is that rare? No, it's not rare. If you look at this patient, once again, 6 days after surgery.
Yeah.
Her cheeks are red because she has rosacea and because of increased blood flow. That's not bruising. Around her lower lids is bruising, but she could put makeup on and go to a party the next night and no one would know. And I just took out her stitches out of her hairline. So what did she look like without makeup before? She looked like that. Let me move that up a little bit. There you go. She looked like that. And then she looks like that, no makeup. So the idea is to create that where patients look female. That has done everything. So in addition to what I originally invented, which is this, that's when I started seeing patients. At the same time, I said, you're going to look more feminine if I do your cheeks, if I do your nose, if I do your chin reduction, because you have a very wide chin. But from the giddy up, I never thought about doing this because, once again, I'm all about proportion. I'm I believe in Da Vinci, contrary to popular belief. He and I were not classmates. And those things are all about how it all fits together. So the final piece was the voice, and that made a huge difference. But once again, without any makeup.
Yeah, you mentioned it, like obviously you said that you don't jawline because of the proportions. You may reduce the chin.
Correct.
But the Adam's apple, that's, not all men have a significant Adam's apple. But for those that...
Well, they do. Almost every one of them has a larger Adam's apple than females, but there are some cis females that have a large Adam's apple. And I do those because of the same reason. Their Adam's apple, it bothers them.
Yes, yes.
And if somebody can remove it safely without complications, then they have it done as well.
Yes.
But in males, the difference is, let me show you this. It looks like this. This is your average patient. That's a little bit bigger than normal. Sorry, 1 second. So that's the before and after. And then this is a much larger one. So at the same time I did that, then I did the final piece, which is the voice. And the Mayer voice procedure works 90% of the time. And I don't discuss that. I just do it. I'll teach it to whoever I turn my practice over to, because it's that final piece. And some patients are able to do it. I say, if you are not misgendered on the phone, you don't need a voice procedure. So that's by definition, that will tell them. If you can do it without surgery, why would you pay to have surgery? Don't get it done. If you're not misgendered, why do it?
Now, I would imagine, again, like everything in the male to female transition is, of course, and in every patient is different. So what would you say in the majority of the transgender male to female patient, do you have to do the voice modification?
Usually, I would say I do it. Most of the patients will come. Some patients come in to be just for that, not anything else. But the majority of patients, it's like a shopping list. I tell them everybody has a budget. So I say, do the procedure that bothers you the most, not that bothers me. I'm not going to look at it every day. You are. So if you say, I don't care that much about my voice, then do what you do care about.
Yes. Yes.
Even though I may think, my God, you should really get your voice done. That's my bias. And I don't force my bias on patients. I tell them what I think, but I'm just presenting them with the pros and cons of a shopping list. And once they know what's in my head about the pros and the cons, then they can decide what's best for them, each patient differently.
You know what I find interesting, because I mean, surgery is surgery, right? Regardless, it's not a walk in the park. It's a serious undertaking by anybody, regardless of the surgeon, regardless of the surgery. And so
Correct.
You see and offer, all these different techniques and treatments for a patient. However, the only in this discussion area of concern I feel from you is the voice. Like you said, you could really, I don't know if it's hurt somebody or change somebody or do something. So what are the risks with the voice modification? Or what is the ultimate risk? Is it?
Well, there's a procedure they do in Korea, and that procedure, patients can't talk for several weeks because you're trying to cause an adhesion of the vocal cords. Mine is different than that. As I said, I just do it. And that you've got the carotid artery, the jugular vein, you're operating on the airway. What could possibly go wrong? Patients, I could sit here and go click, 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 and show you the simplest of procedures with horrific results.
Yeah.
And they would have no play. In my hands, I've never had a serious complication from the voice procedure. Zero. No infection, no bleeding, no airway problem, no bad voice. It either works or it doesn't work.
Yeah. Yeah. Okay, because that is, I mean, of course, that's for the male that does have a very male voice. They change to looking more feminine, then they want to continue that appearance, I would imagine. But then, like you said, for some people, that's fine. They're good with their own voice.
And some patients are able, with voice training, to get their voice where they want it to be without needing surgery. And I said, great, more power to you. I had a patient that I did a week and a half ago who came in and it sounded like, oh, you don't need a voice procedure. Wow, your voice is so good. And she said, well, this isn't my natural voice. I said, well, speak to me in your natural voice. And I went, oh my God, that was such a huge shift. And she did a great job, but I did a voice on her because she said she had to think about it. And she wanted to be where she was in situations where she didn't want to think anymore about having to do that. So I'll have some patients that want to use it for that. And remember that some patients, it just doesn't work. So they have to understand that. But once again, the most important thing is that in my hands, there's no serious complication with that procedure.
That's good. That's good. That's good. Well, let's just talk now more in general about your patients. And can you share with us any kind of anecdotes of life-changing things?
Sure. Let me show you this one. It's life-changing to go from the patient there on the right to go to that on the left. Oh my gosh. Yeah. So that, and what you see, you say, oh my God, that is definitely a male face, huge supraorbital bone, big recessions, wide chin, huge nose. Okay. She's had everything done except her voice. Adam's apple shave, cheek implants, nose, lip lift, fat augmentation to her lips. She's had a hairline lowering, no remove and replace her supraorbital bone. Her recessions have been narrowed, and she's had 150 micrografts on each side. And she sends me this 2 weeks later.
Oh, wow. Yeah.
So that's what people want. They want the outside to match the inside. So patients like that it's just life-changing. Patients said, I never felt comfortable going out into the world. I was always worried. Now I don't worry anymore because the outside now matches the inside. 6 days later, when I show a patient there before while they're sitting, we just removed their stitches at 6 days, and I get in the mirror, tears are pouring down their cheeks. That's how life-changing this is, and that's why I still keep working.
Yeah.
Because it is very rewarding for me, and it teaches you how just small things, for me, make huge impact where I'm changing their life forever. My wife still tells me to take out the garbage, however. So there's no justice in the world. What can I do?
Yeah. But, I think when you said earlier that, to make the transition from male to female or female to male, whatever it is within the transgender, it's something that has chosen that person. Nobody would choose to walk this path because it's a difficult journey. But so difficult, costly, time, life, so many life adjustments, and to then walk through life where the inside and the outside are now matched. Yeah, well, would you say, given that you were the pioneer in most of these techniques and one of the very first surgeons to be doing, the facial feminization, and then you have grown in your own career to where, you're the man everyone turns to for facial feminization, would you say it chose you?
Oh, yes.
What
it's funny because I always wondered why I never made a judgment. You would think that doctors wouldn't judge, but plastic surgeons, as I said before, didn't want transgender patients sitting out there with their other patients. I never cared about that because the idea was to change. As a surgeon, if you have a tumor, you remove it. Patient now is fine. And people say, oh yeah, that's great. Wow, you removed it. That was terrific. But if you said, how about a hump in the nose? If you remove that, is that different? Well, no, because that patient all the time looks around and 2-year-olds know which one the pretty is. They say, oh yeah, that one's pretty, that one's not. So we all have that, whether we like it or not. It's a judgment that we all have, and it may not bother this person. They have a nose that walks in the room 5 minutes before the rest of their body, and it doesn't bother them. I say, don't have it done. They say, oh, my husband wants me to have a facelift. Don't have it done. If you don't want it, don't have it done. It's about you, not about him. So in the early days of transgender surgery, I never saw any difference. So I just kept doing transgender patients along with my cisgendered patients. And now I don't, the only cisgender patients I do are my relatives who want to get me before I die. So they say, well, could you, I have friends similarly who say, could you possibly, but they're the only cisgender patients I do, except for special circumstances.
Yes, yes, yeah. Which I think is an amazing feat, and again, just is showing the change just in our community and in our world. In that, if you've gone from being busy, 4 or 5 days a week with a cisgender patient base, and now you're as equally as busy with a transgender patient base, there's clearly, an audience and a big group out there in need of the services and procedures that you can offer, which I think is wonderful. And I think, like we've just talked about, the general acceptance and the fact that you can feel comfortable with, I don't know if you advertise or kind of how you get comfortable with even having a website that caters to the transgender patient, whereas maybe 30 years ago, well, websites weren't around, but in the early days of websites, perhaps that wasn't of what we saw on the internet, whereas now there's so many more resources available to that population.
And that has a good and a bad, because people can say that they're a transgender surgeon, but I tell patients, they say, well, how do you choose a transgender facial feminization surgeon? I say, results, results, results. People, I have patients in and out. So a new patient that I'm seeing, they can see somebody here. I did this patient 6 days ago. Take a look at them.
Yes.
There you go. If I'm talking to a patient and they say, I saw Dr. So-and-so and, he said, and I go, well, if you feel more comfortable with that doctor, by all means, go to that doctor. Why would you come to me? If I felt more comfortable with this other doctor, but you better make sure the results are what they really are, because that's where I could show you really bad things and if we could go back in time and ask those patients, is this what you thought you were going to get? No, absolutely not, because the patients got really bad things, some of which cannot be fixed. So it's unfortunate, but that's why patients have to do their homework. It's about results.
Yes.
See live patients. People who are good transgender surgeons who see patients day in, day out, they will have them in their office. See a live patient. I don't care. My patients will gladly talk to anybody. So there's a few that are high-end that are still in the closet because no one knows they're transgender. They look too good. And so no one would ever know.
And that's a choice. In this day, that's a choice if you say they're a high-end patient and they prefer to remain anonymous about their choices, and that's okay.
That's okay.
Well, and I do think it is, even with all the acceptance and everything within the community, it is still a vulnerable community of patients. Mm-hmm. And with that vulnerability is what you're saying is, there can be misleading information, or there can be people who are just kind of jumping on the bandwagon. Maybe they're not really that qualified then, and that's in anything in cosmetic surgery. I think we see more people who are just jumping on the bandwagon doing techniques they have no business doing. But what would you say to a transgender patient who is now ready to make that move, to have facial feminization? How would they find a surgeon? What should they be looking for? You say, yes, they can see patients within your practice, but do you introduce them to a patient? Can they talk with a patient? What steps or tips would you offer to that patient who is now embarking on that path to facial feminization?
Well, there are many avenues for transgender patients, and that's good news and bad news, because people who are not as competent can go on there and they can get good reviews from their patients saying, okay, but without seeing the before and after, or better yet, a real live person being referred by someone who is transgender. So if they can talk to other patients and find out, usually within the transgender community, they will know who the bad surgeons are in general, but you've got a new crop of transgender patients every year, and they're very often, unfortunately, like lambs being led. It's just results. Talking to patients who have had the work and seeing their results is the best way. And then you can go to several, let's say you get 3 names, go to all 3 of them and see what they have to say. So I have patients who were scheduled with another surgeon, and they talked to a patient of mine who said, oh, no, this is the person you should go to. And that, even when I see those, I say, if you're more comfortable with that doctor than you are with me, I tend to be very bam. Yeah. That I'm not there to schmooze somebody. I'm there for results. We've had patients who have seen somebody and they have the surgeon never discussed risks of the surgery, and some are so significant that the patient would not have had that surgery had they known that risk. Okay? Especially like bullhorns. Everybody does a lip with a bullhorn. I never use a bullhorn. I put my incisions inside the nose, and they might have a little line there. That's all I do. I never go through the mouth for a chin reduction. I go through a 1-inch incision in the crease here because that's painful. Lasts for weeks. You got to pull this down. It stretches the mental nerves, and you get temporary or permanent numbness. The patients, are they told that?
No.
Usually not.
No. And they're questions patients wouldn't even think to ask.
Yes, I have a list that I go through with every consultation so it's idiot proof. Yeah. So I don't have to say, oh, did you discuss this with the patient? It's right there. Boom, boom, boom. I go through each one of those things with every patient.
So what about the age of the patient? So, when you talked about, in the early days and being one of the few, or whether it's today, it's the cost of surgery or the timing of a procedure, have you seen a change with the age of the patient coming in for facial feminization, or is it?
That's a yes and no. I don't see patients who are usually under 18. I can't remember if I've ever seen a patient under 18. If I did, I told them, don't do anything. Now, unless it's interesting when you talk to patients about when did you know you were transgender? And they'll say, oh, I knew when I was 5 years old, 6 years old, 8 years old, somewhere that their parents knew about it long before then, usually because it's all the reasons that we know now that the general public knows that, boys that want to play with dolls and want to wear female clothes, and they will tell you, no, I feel like I'm a girl. Patients know this, and as you said, they wouldn't do this without extreme motivation. Somebody doesn't just decide one day to be transgender. So the average patient that I saw then versus I see now is still roughly the same. I see patients in their 20s, 30s, 40s, 50s, even in their 60s and 70s, patients who had certain things done, but at the time they had it done, they weren't aware of these other possibilities, and now they are. But that's the exception. So I'd have to go back and see, but the average patient, I would say, is more likely that I see is more likely to be in their late 20s up till 55.
Okay.
That's the majority fit in the bell-shaped curve.
Yes. Yeah. Well, it makes sense. I mean, I ask only because I would think, for those patients in their 60s and 70s, they've kind of waited a long time to be the person they felt they should have been when they were 5 years old.
Yeah, but you know what happens though? It reminds me of a patient I saw who was 65 years old, and she came in for a rhinoplasty, cosmetic rhinoplasty, and I said, it's a little unusual for you to come in at this age. Why is that? And she said, well, when I was a young girl, I wanted to have it done. My father wouldn't let me. And then I got married and my husband wouldn't let me. And now they're both dead. I can go do what I want.
Okay. Yeah.
And that's the truth.
Yeah.
I mean, that's the nature of what this is, because once again, it's the job, my job, as I see it, is to remove this pain from the patient. And people go, oh my God, you got a hump in your nose. People are starving in Africa or in China. And why do that? And I say, because it's the same. It's, the man who was complaining about his feet being cold when he saw a man with no legs. And you go, yeah, but the man still had cold feet. That's his stuff. His stuff is cold feet. So you go, the same thing with whether it's noses with a hump or transgender issues. It's still the same.
Well, I think as well, it's like if you can help a person, or a person can help themselves be the best version of themselves, they serve more purpose in the world in general, because they're happier, they're healthier, and they do something they love and with purpose.
These issues affect everyone. Somebody said to me, oh, so do you think I need a facelift? I said, do you think you need a facelift? And they go, well, I don't know. Would I tell Mother Teresa that she needed a facelift? No. If she asked me, would she look better with a facelift according to Western standards, I'd say absolutely. So you see pictures of patients, the patient of the African-American patient that I showed you. I do patients in their 60s who I'll also be doing, besides all the transgender surgery, I'll be doing a facelift and or eyelid surgery at the same time. So I do all of their surgery in one day, all of it. If they want to have everything that I do and have a breast augmentation, I don't do breast augmentation, but I don't have a surgeon do that on the same day. They could have it a day or two later. So they have one recovery period, but not that day.
My last question to you on the transgender is in terms of the patient and the change that it makes in them. Is there any particular patient who you can say it really made a difference in their life because, they went on to a happier career?
I have a patient right now who's engaged to be married, has a partner who's male, and they're transgender. And this has nothing, I think another thing that we didn't talk about is transgender surgery has nothing to do with sexuality. In other words, meaning I have patients who are transgender that sexually can have they can retain a penis. That's their choice. I mean, if that's what they want to do, they can have a partner where that works for them, but it's all combinations. Transgender patients who eventually marry females, marry males, all sorts of different arrangements, because the sexuality is separate. So, but they're still just so life-changing. Over the years, I've seen so many. I had a patient that I did who had a business. I did her surgery. She said a year later, a customer came in and said, "Oh, excuse me, Jerry's not here anymore." And she looked at the customer and said, "No, Jerry's not here anymore." Because that was her. He never realized it.
Yeah.
And if she wanted to say, "No, that's me," she could. But if she didn't, would never know. And this is somebody that came in regularly into that business.
Or it was the person that should have been there the whole time.
Exactly. And now, I mean, if someone said, what if I was transgender? And I felt like, oh, nothing in my life is normal. I can't wear the clothes I want. I can't put on makeup. I can't be with the person I want to be with. I'm just a total fraud. We just living with that. And as I said before, you can't say it too many times based on the current political climate. It chooses them. They don't choose it. So.
And I think one thing that you can kind of wrap it up with, as you said, is this isn't a sexual issue. This is not about sexuality.
Correct. Absolutely not about sexuality. It's about who you are inside.
Yeah.
And you know, you hear this all the time. They say, "Oh yeah, they're a female trapped inside of a male body." But I don't think people stop and actually, I mean, it's natural. They don't stop and think, what does that mean? What does it really mean if I thought about myself being that way and everybody I relate to, my family, friends, society was the big one. So what's the biggest change? Society acceptance.
Well, the patients that you have, they are able to go on and continue to live or go on and live better lives than they did before, be in relationships that they want to be in. And when you say it's not about sexuality, it's about becoming that person and becoming true to themselves, then the ultimate goal with that is love is love. And
there you go. There it is. Yeah. So it's with those people. They want to be loved and cared for and be who they are and loved for who they are, like the rest of us.
Thank you so much for being on the Aesthetic Insider Show. When our conversations on facial feminization, the transgender patient, has been amazing. I really enjoyed having you here, and thank you. Thank you.
I've enjoyed being here, and I hope your audience found this informative. And now when they meet a transgender person, hopefully they will have more intuition than they had before.
Absolutely. Well, again, thank you for being on the show, Dr. Mayo. And for those of you still watching, I hope you enjoyed today's show, and please make sure to watch next Wednesday for more exciting guests. Thank you.